Welcome to the Deep Dive, the place where we cut through the research noise and deliver the essential knowledge straight to you. Today, we're diving into a really crucial question for anyone in sports or physical therapy. Can we find a near instantaneous way to fix a persistent, nagging problem? We're looking at a physical intervention so quick it could fundamentally change how we warm up or, prehabilitate injured joints.
And that's really the core mission of this deep dive. We are examining an extremely well-designed study that focused on quantifying the acute functional effects of a very specific intervention.
So what's the source material for today?
The article we were pulling from is titled Acute Effects of Floss Band at Different Pressures on Multidimensional Ankle Stability in Patients with Chronic Ankle Instability. It's a randomized controlled trial.
Okay, that's a mouthful.
It is. The work was led by Yuanhao, Chen and a team of colleagues, and it was published in the highly respected Journal of Sports Science and Medicine back in 2026.
Okay, let's unpack this and set the stage. The focus is chronic ankle instability, or CAI. For you listening, we need to understand why this condition is such a massive drag and, why finding a rapid fix is so valuable.
Well, CAI is just endemic in active populations. If you sprain your ankle just one time, you have up to a 50% chance of developing this persistent instability.
50%? That's incredible.
It is, and it's not just a lingering weakness. It's a failure of the entire system. CAI is characterized by these recurrent giving way episodes, chronic pain, and this is the critical part, long-term functional deficits in two key areas.
And those are?
Neuromuscular control and proprioception.
Proprioception. Okay, so that's that essential sixth sense, your body's ability to know where your foot is in space without actually having to look at it.
Exactly. And when you lose that, you lose critical milliseconds. Milliseconds you need to stabilize the joint during, say, landing or cutting. The current gold standard for this is functional training, which is effective,
But this takes forever.
It requires weeks, even months of consistent work to see measurable changes in these deep-seated neurological patterns.
So if the long-term solution takes too long, the sports community naturally starts looking for a shortcut. The idea here is an immediate reset button, something that gives you a significant functional improvement, right now.
And that brings us to the intervention they tested, the compression tissue flossing band, or just FB.
A floss band.
It's a thick, durable, elastic band that you wrap tightly around a joint or a muscle. The authors hypothesized that CAI patients, because they have these demonstrable deficits in their sensorimotor systems, would represent a kind of perfect therapeutic window for this.
A therapeutic window, meaning they have more room for improvement.
Precisely. A lot of the previous research on floss bands was, frankly, inconclusive, but that's largely because it tested healthy people where the system was already working just fine. There wasn't much to improve.
So what are the researchers suggesting is actually happening under that intense compression? Why would wrapping a band around your ankle suddenly improve its stability?
They laid out three primary sort of synergistic mechanisms, and it goes way beyond just, simple mechanical stretching. The first is what they call enhanced fascial sliding.
Okay, break that down. Fascia.
Think of the fascia, the connective tissue around your muscles, like cellophane wrap. If it gets sticky or restricted, movement is restricted. The compression plus the movement forces those layers to glide better against each other.
So that sounds pretty physical, like optimizing the hardware. What about the nervous system, the software?
That's the really critical part. Mechanism number 2 is pain modulation through the classic gate control theory.
The gate control theory. That's the idea that if you, say, bang your elbow, rubbing it makes it feel better because you're sending other signals to the brain, right?
You've got it. The intense pressure from the band stimulates these large, fast-conducting sensory fibers. When you flood the central nervous system with all this non-painful sensory input, it essentially closes the pain gate, overriding the smaller, slower signals that carry that chronic pain or discomfort. It's a sensory distraction that lets the body move without being so inhibited.
That is ingenious. So what was the third mechanism? You mentioned it relates to blood flow.
Correct. The third one involves the physiological responses to transient blood flow restriction. That's the ischemic phase when the band is on, followed by this rush of blood when you take it off. The reperfusion phase.
A flood of new blood.
Yeah, and this rapid cycle can flood the area with metabolites, maybe stimulate some cellular repair, and it could modulate the whole neurometabolic environment of the joint. All three mechanisms are aimed at optimizing sensory input and just making the body's reflexive stability mechanisms more efficient.
This is where it gets really interesting for me. The pressure. If the sensory input and the blood flow are the active ingredients, then the pressure level has to be precise. The study noted that previous applications used this huge range from 100 to over 210 millimeters of mercury. How did this team decide where the sweet spot was?
They recognized this huge variability was probably why past studies were so inconclusive. So they chose two very specific, distinct levels. They picked 150 millimilli-BHG as their medium pressure, or MP.
Okay.
And that had been sort of hinted at as being beneficial in other work. Then they chose 200 millimilli-HG as their high pressure, or HP.
And that was a deliberate choice, to push it that high.
A very deliberate choice. Because some initial work suggested that 200 millimilli-G might be too much, it might offer no benefit, or could even be counterproductive. They were essentially testing a hypothesis.
Yeah.
Is there a point of diminishing returns, or even adverse effects from maximum compression?
It's basically a Goldilocks test for the ankle. Not too little, not too much. So to test this, they needed a really high-quality methodology. Tell us about the setup of this randomized controlled trial.
It was meticulous. They recruited 42 male participants who all had confirmed unilateral CAI. They split them into three groups of 14. You had the MP group at 150, the HP group at 200, and then a control group.
And the control group, what did they get?
Crucially, the control group received a visually identical but non-compressive elastic bandage wrap.
That's a great blinding technique. But I have to ask, if the intervention is so intense, 150 and 200 millimilli-HG are significant pressures, wouldn't the participants in the control group know immediately that they weren't getting the real treatment?
That's a sharp and a very necessary critique of any kind of banding study.
Mm-hmm.
And you're right. While they attempted blinding, it's fair to assume the subjective feeling of extreme compression is pretty hard to mimic.
Right.
However, the blinding did ensure that the exercise routine and sort of the ritual of the band application itself were standardized across all groups. So it helped control for the placebo effect of just receiving any treatment and then exercising.
And that exercise protocol was standardized too. They didn't just wrap the ankle and have them sit there.
No, absolutely not. The compression with movement idea is key. While the band was on, for a strict 4.5 minutes, all participants did a standardized routine. Active ankle movements, bilateral heel raises, forward lunges, and single leg deadlifts.
So challenging movements.
Yes. This active movement, while compressed, is designed to optimize that neural input and mechanically challenge the tissues while they're under pressure.
And they tracked the outcomes for quite a while afterward. I saw it was baseline, then 5 minutes, 25 minutes, and 45 minutes after the band came off. They were tracking the immediate effect and also the duration. So what did they measure?
They focused on 3 dynamic functional domains that are just crucial for ankle health. First, dynamic stability. Stability while you're moving.
How do you measure that?
They measured this using the composite score from the Y-balance test. It requires the participant to balance on one leg and reach as far as they can in 3 different directions with the other foot. A higher score means better functional control.
Okay, that makes sense. What was second?
Second, neuromuscular control. Basically, how fast and efficiently your muscles fire to catch you when you land.
And they measured this with EMG.
Exactly. They used surface electromyography, or SEMG, during a dynamic single-leg landing task. They measured the electrical activity, the root mean square amplitude of 3 critical muscles: tibialis anterior, lateral gastrocnemius, and the peroneus longus.
And the peroneus longus, the PL, that's the big one for preventing that classic ankle roll.
That's the one. It's a primary muscle for fighting inversion. Measuring the RMS, especially in the pre- and post-activation phases, tells us if the muscles are waking up faster and stabilizing harder after the landing.
Got it. And the third measure was the sensory feedback loop itself, proprioception.
For that, they used an active joint position sense task. The patient had to replicate a specific angle 15 degrees of inversion without looking, and the researchers measured the error. Lower error means better sensory accuracy.
And they looked at static balance, too.
They did as a final check. They assessed static balance using the center of pressure, or COP sway area, during a single leg stance.
All right, let's get to the results. This is where the differences between 150 and 200 millimilli-HG should become really stark. So which pressure level provided the most meaningful, long-lasting benefit?
The medium pressure group, the MP group at 150 millimilli-HG, was the decisive winner across almost every single metric, and the duration was the key.
Okay, tell me about the dynamic stability, the Y-balance test.
In dynamic stability, both the MP and HP groups improved significantly right after the intervention, at the 5 and 25-minute marks. But the most clinically relevant finding was that the MP group maintained significant functional improvements all the way up to T3.
So 45 minutes after the band came off.
45 minutes later, The high-pressure and control groups, their benefits just rapidly faded away.
That 45-minute window is huge. It means an athlete could use this band as a warm-up and have a substantial window of enhanced stability that lasts through a practice or a pre-game routine.
It's a game changer for pre-activity prep.
Okay, what about neuromuscular control? Did 150 millimilli Hg actually make the muscles fire faster and harder?
Yes, significantly. Both Floss and groups saw an immediate increase in that RMS activation, meaning the muscles were firing more vigorously during the critical pre- and post-activation phases of landing. This is that neurofacilitatory effect we were hoping to see.
But again, the lasting power belonged to the medium pressure group.
Absolutely. The MP group demonstrated much longer-lasting benefits. They maintained that elevated muscle activation at the 45-minute mark, specifically in the lateral gastrocnemius and, crucially, the peroneus longus.
So let's translate that for you listening. Elevated post-activation from the PL means that when you land and your ankle starts to roll out, that key stabilizer muscle is contracting faster and harder than it was before the intervention. It's directly protecting you.
Exactly right. And that protective change lasted significantly longer in the 150 millimilli G group.
It is truly remarkable that you can modulate the speed and strength of a protective muscle contraction in just a few minutes. So how did the sensory feedback system proprioception respond?
It followed the exact same definitive pattern. Proprioception accuracy in the MP group improved substantially and sustained those improvements from T1 all the way to T3. 45 minutes.
Wow.
They significantly reduced their angular replication error. The HP group, the high-pressure group, only showed a fleeting transient gain at that first time point, and then their accuracy quickly dropped off, mirroring the control group.
So the higher pressure 200 millimilli Hg was strong enough to stimulate the system initially, but it just couldn't sustain the effect. It's almost as if it overloaded the circuit.
That's the interpretation. And before we get into why, let's quickly touch on static balance. The results here were a bit mixed.
Okay.
While both groups did reduce their sway area at T1, the improvements in static balance were generally pretty limited and transient. This suggests that floss banding is primarily optimizing dynamic, rapid response stability, not just passive standing balance.
That makes a lot of sense. I mean, the intervention requires dynamic movement, so the benefits should really apply to dynamic tasks. So now let's tackle the central question of this deep dive. Why did 150 millimilli Hg work so well, and why did 200 millimilli Hg fall so short in maintaining that benefit? Why is more compression not better here?
The researchers proposed that 150 millimilli Hg represents the optimal regulatory pressure. It was just enough to trigger the sensory feedback and the physiological processes, the pain modulation, the reperfusion, without causing excessive stress on the system.
And the 200 millimilli Hg at the high pressure.
That excessive pressure may have inadvertently worked against the intended effects. High pressure could cause a couple of problems. First, it could prolong the ischemic phase too much, which would then impair the reperfusion that's so critical for that metabolic flushing and neuromodulation.
Okay.
Second, and maybe more importantly, excessive pressure might overstimulate the mechanoreceptors to the point of triggering a protective inhibitory reflex.
An inhibitory reflex. So you mean the nervous system interprets the extreme pressure as a potential danger, and its protective response is to actually make the muscles less efficient, to sort of slow things down.
Exactly. It's a mechanism to protect the limb from damage. If the body senses this overwhelming pressure, the central nervous system may actually reduce muscle activation efficiency and sensitivity to prevent strain. This is a crucial takeaway.
So it's like the difference between talking to someone to get their attention versus shouting so loudly they just cover their ears and shut down.
That's a perfect analogy. Exceeding that optimal threshold, in this case 150 millimilli Hg, can be counterproductive. It can lead to only transient or maybe even detrimental effects. And that realization should guide acute interventions far beyond just ankle flossing.
This really emphasizes that the primary mechanism here is neurophysiological and neuromodulatory, not just mechanical. You're essentially recalibrating the ankle's software, not just stretching its hardware.
You are. And that's why the active movement during those 4.5 minutes is paramount. This compression with movement approach is what differentiates FB from, say, passive short-term stability aids. By actively moving and performing challenging exercises while the sensory pathways are being flooded and modulated, you're immediately strengthening and optimizing those neuromuscular control patterns.
Which makes it an ideal pre-activity tool because it doesn't suffer from that transient strength reduction you can sometimes get from prolonged static stretching.
Precisely.
Now, before we wrap up, We should always acknowledge the limitations. This was an acute study, so the findings only hold true for that 45-minute window, and they only used male participants.
That's important context. We don't know the long-term effects or what the optimal frequency for repeated use might be, and because they only included males, future work absolutely needs to investigate whether females, maybe due to differences in ligament laxity or fascial properties, respond differently to these specific pressure levels.
But the immediate takeaway is exceptionally clear and actionable for practitioners. A single, brief, 4.5-minute application of a floss band, specifically calibrated to 150 millimilli Hg, is proven to rapidly enhance dynamic stability, neuromuscular control, and proprioception in patients with chronic ankle instability.
And it provides functional benefits that last for nearly an hour.
An incredible result.
This knowledge provides tangible, evidence-based guidance for improving pre-activity performance and mitigating that immediate re-injury risk. If you are involved in sports rehab, coaching, or you're just interested in the precise metrics, we strongly encourage you to seek out and read the full article by Chen and his colleagues for all the statistical depth.
And if you appreciated this deep dive into some complex scientific material, make sure you follow the channel and turn on your notifications so you don't miss future discussions on what matters in research. And to leave you with a final thought to mull over, if the active movement under compression is what drives this functional, lasting change in the nervous system, how does that make the floss band superior to other stability aids, like traditional athletic taping, which provides passive support without demanding that same level of neural engagement?
That's a fascinating pathway for future thinking.
Thanks for diving deep with us.